Start recording, please. Go ahead, Majid.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. This is Dr. Majid Barhamin, consultant nephrology. On behalf of Saudi Society of Nephrology and Transplantation, I would like to welcome all of our attendees for this evening webinar, The Evolving Landscape of Anemia and Management. Our distinguished speaker today is Professor Danilo Fliser, Professor of Medicine, Director, Department of Internal Medicine, Renal and Hypertensive Disease and Transplant Center at Saarland University Medical Centers at Hamburg, Germany. Prof. Fliser, he had different academic appointments since 2018 till now. He appointed as Renal Science Chair of the European Renal Association, European Dialysis and Transplantation Association, ERA Edita. He earned many rewards and honor. Prof. Fliser has more than 360 original publications listed in PubMed and more than 20 research publications with an impact factor. With all this rich background, join me to welcome Professor Fliser, and the floor for you, Prof.
Thank you very much. It's a very nice introduction. Thank you very much. And I'm very pleased and happy to be able to speak tonight to you. I have to say, unfortunately, because of COVID, we are now all online, but I have been to Saudi Arabia and enjoyed your warm hospitality roughly about 50 years ago. However, then I was talking about ARCs and progression, and actually progression of kidney disease is a main focus of our research, and part of that is also anemia management. So again, thank you very much for this invitation. I'm very grateful to the Saudi Arabian Nephrology Society, in particular also to the sponsor, to Astellas, to giving me the chance to speak to you. I will now share my screen, and I hope you can all see it without problems. And the title tonight is The Landscape of Anemia Management of Chronic Kidney Disease. The point is, and I will scroll on the conflict of interest that I have, and a disclaimer. The point is that anemia is a quite frequent complication in patients with chronic kidney disease. However, there are still problems treating and managing patients with anemia associated to chronic kidney disease. And this is the lecture outline for tonight. I would like to review some facts and also some fiction about anemia related to chronic kidney disease, particularly the clinical significance and prevalence in our population, our patients. Then I will review the treatment guidelines, particularly the KDIGO guidelines with you, and look what problems they may have for concrete proposals for treatment of our patients regarding anemia, the problems related to the management of CKD-related anemia. And of course, finally, we will go to the new class of drugs available for treatment of anemia related to CKD. However, I've heard before that you had already many talks about this, so I will focus today on a particular aspect of these drugs, that is inflammation in our patients and how we can go over this or beyond this inflammation with the new class of HIF Prolyl-Hydroxylase inhibitors. So let me start something more general about chronic kidney disease. Here is one of the latest publications about that. You see here in Lancet 2 years ago. By the way, I don't know if you have realized the new impact factors of the journals which came out the day before. Lancet is now #1 with an impact factor of more than 200, overtaking even New England Journal. So what tell this publication to us? We have across the world a huge proportion of patients with chronic kidney disease. Roughly, it is estimated around 9% of the world population having a reduced kidney function, having chronic kidney disease. But what is even more important than the progression and the reaching end-stage kidney disease is this here, the so-called DALY or disability-adjusted life years in our patients, as you can see, and they are high. Also in your country, you can see here, and also in other countries. What does that mean? That means that chronic kidney disease are associated with this large burden, a large comorbidity burden to our patients, and particularly cardiovascular comorbidity. And this is independent, as you can see here on the next slide, independent of the cause of kidney disease. Of course, we know that diabetes here in red columns is a leading cause of chronic kidney disease. Nevertheless, underestimated is hypertension, here showing in blue, but also other diseases, glomerular diseases, or unknown or unrecognized diseases. They all contribute to this DALY or disability-adjusted loss of life years due mainly to cardiovascular morbidity. And we have summarized this in a recent review paper together with a co-worker, Professor Speer. And as you can see, we have published this overview in the European Heart Journal, which is the highest ranked journal, cardiology journal, even in the world. Why it is so important and known for cardiologists? Because our patients have a tremendously reduced life expectancy due to cardiovascular diseases. And if you are a patient in the age of 30 having chronic kidney disease in a more advanced stage, as you can see with a GFR below 30, so CKD stage 4 and higher even, then you have a reduced life expectancy up to 30 years. That's tremendous. And what are the contributors? And we have in our department a large research established by the German Research Society. We just recently got a grant over 12 million euro for investigation of some of the causes of this high cardiovascular burden in our patients. One very important is inflammation and post-translational modification of peptides and proteins and lipoproteins. And I will come later on in my talk on this. But also anemia is an important contributor to survival, to cardiovascular complication. Virtually all these studies done in previous years, like those here 15 years ago, published in a CKD population from the United States. You see here almost 60,000 patients on hemodialysis, and the best outcome hemoglobin actually adjusted is around 12 to 13 grams per deciliter. And almost every study has shown this. And even in non-dialysis patients, here a study by Adera Levin from Canada and published in NDT in non-CKD patients with a GFR of 21. Here they clearly could show the higher the hemoglobin, the better the outcome, the better the cardiovascular outcome. Nevertheless, the prospective interventional studies have shown another picture, and I will discuss this with you also after that. But one important aspect, which is almost always forgotten by us, because as physicians, we actually always look on hard outcome, like death, like dialysis, like stroke. But what is important for our patients is the quality of life. And I have many patients, they tell me, well, doctor, I want to have good years of living, not too many, but good one. And this is quite important because anemia is a major contributor to reduced quality of life. And this you can see in non-dialysis dependent CKD patients and dialysis dependent patients. The so-called EQ5D3L utility index, which actually assesses mobility, self-care, social activities, and so on, is reduced with declining hemoglobin levels. And this is independent of the stage of CKD. As you can see, stage 3, stage 4, and even dialysis, the lower the hemoglobin levels, the more is the quality of life of our patients reduced, everyday life. They get socially isolated, depressive, and so on. So it's important also to correct anemia, to improve the quality of life in our patients, and therefore anemia management is a key component of integral CKD management. And the question is, of course, when does anemia start? Because we have to look at it. The patients will not come to you and say, well, look, I'm anemic, I need a treatment. You have to look at it. You have to ask for the symptoms. And you can see here in CKD stage 4, more than 40% of patients already are anemic. They are anemic with a hemoglobin level below here 10 gram per deciliter. And if you are diabetic, this is even worse. Diabetics have up to 80% anemia in this particular stage. And it starts early. You see here already when GFR declines below 60 milliliters per minute. And despite being anemia, the second most important or frequent complication of CKD, as you can see, beside hyperparathyroidism, the treatment is tremendously low, surprisingly low. More hyperphosphatemia or hyperkalemia is treated than, for example, anemia. Why is this? This is an older study before the KDIGO guidelines came out. But it is a similar picture in older studies with patients on dialysis, as you can see, where almost just 60% in incident dialysis patients reached a hemoglobin of 11, and the prevalent patients were even worse. They didn't reach, not even half of them, a hemoglobin level of 11. Why is this? Because we've got this nice guidelines, the KDIGO guidelines, you know them all. They are quite old. They will be renewed in roughly about 2 years. We will have an update of these anemia KDIGO guidelines, probably 2024, or even sooner, 2023. Nevertheless, in these guidelines, there is a comprehensive proposal how to diagnose, evaluate, manage, and treat anemia related to CKD. Nevertheless, how are the more recent data on management? If you look at this study where we also participated, this is the so-called CKD study. Probably many of you know this study. It is a study done not like the DOP study in dialysis. CKD is done in CKD stage 3 and 4 in 5 large countries: Brazil, France, Germany, Japan, and United States. And we have contributed until today almost 3,000 patients. This is a more past publication. And I can show you very new data on anemia treatment in patients on dialysis. And this is surprisingly, let us look at the German data. And as you can see, dependent on CKD stage, here there are almost 40% of patients in whom non-TSAT or ferritin measurement has been done. And if you look at by hemoglobin level below 10, this is here, or the same picture. Half of the patients have not a measurement of TSAT and ferritin. And if you look at ferritin levels, as you can see, the measurements are not done despite having 1/3 of patients with very low ferritin levels, either by CKD stage or by hemoglobin level. 1/3 of patients with a hemoglobin below 10 does not have ferritin measurements in the pre-dialysis settings. And the same is true for TSAT. Even worse, as you can see, TSAT below 20, more than almost half of patients here and more than half of patients here do not have a TSAT measurement, despite being grossly anemic with a hemoglobin level below 10. And if you look to the achieved hemoglobin levels, you can see that almost half of patients have a hemoglobin level much below 11, which is, as I will show you, against the guidelines. And if you look at the treatment, and these are really new or fresh data, then you're quite surprised, because 1/3 of patients has non-treatment for anemia in CKD stage 5. And even those with a hemoglobin level below 10, 60% have non or ESA only, which is not according to guidelines, because the guideline says, and I will point this out, iron first. Okay, so taking together, despite the availability of these guidelines, there is much room for improvement in the management of CKD related to anemia. And you see here these Western, so-called Western countries, they do not really perform perfectly. We have almost 1/3 of patients non on dialysis with hemoglobin levels below 10. And I'm quite sure it is not very different in other countries. And the reasons might be different guidelines, different approaches. It's not only KDIGO, there are hospital guidelines, there are national guidelines, and it is a bit disturbing for all the physicians which guidelines to follow. And there is another point, that many hospitals do not have standard operation procedures, how to manage patients with CKD-related anemia, how to approach them, to diagnose and to manage them. So what are the possibilities of anemia treatment we have so far, or we had so far? As I pointed out, iron management is now the first-line treatment. I will show you shortly, according to KDIGO guidelines. ESAs, or erythropoietin stimulating agents, are the second line, and blood transfusion should be actually just a rescue treatment, a rescue therapy, not a third treatment therapy. And iron first is now the prerequisite in anemia management, despite, as you can see here, the timeline of anemia, of evolving anemia therapies, despite having iron treatment, oral iron treatment, almost 200 years now for anemia. But only in the late 90s, the increasing use of intravenous iron was performed. And now we are coming to the KDIGO guidelines. What do they say? According to iron, quite complicated. And what I would like to point out is the graduation of this recommendation. As you can see, many of these guidelines are not graded or have a very low grade, which in turn means there are not sufficient great large studies really supporting this recommendation by hard data. But what they are telling us, we can make it short. Start iron administration. However, the starting hemoglobin level is not specified in the in the guidelines, but there is a TSAT level below. Iron treatment should definitely be started. This is when TSAT is below 30%, below 20%. It's an absolute iron deficiency. I'm here quite very practical, and I say I would choose the same hemoglobin level as with the ESA treatment, which means, and I will show you, start the iron treatment definitely when hemoglobin levels falls below 10. What about patients who are already on ESA therapy, not naive to ESA? Also here, the graduation is not very high, and we can shorten this. Iron administration in patients on ESAs. Again, we have no starting hemoglobin level, but I would propose very practically, definitely when hemoglobin levels falls below 10, or when you have to increase the ESA dose. So if you use too high ESA doses, you should look at iron indices, and if TSAT is low, much below 30, you should start iron. But then the next question arises, oral or iron intravenous? And that's an important question, and this was heavily discussed in previous years. And we have one very important study done by Jan McDougall from UK, who could show that when compared intravenous iron, here on the left-hand side of the cartoon, you see they have achieved high ferritin levels with 1,000 milligrams of intravenous iron, lower ferritin levels with 200 milligrams, or the third arm was treated in a randomized order with all iron. Please have a short look on the characterization of these patients. Non-dialysis patients, GFR 32 milliliters. And very importantly, look at this serum CRP levels. The serum CRP levels in these patients in the mean were already increased. There is a considerable inflammation in our patient present, and this becomes worse and worse with progression of kidney disease. In dialysis patients, almost all patients had an increased CRP level as indicating inflammation. Why is this? I will come later on. What happened in this study? Of course, those patients having intravenous iron, aiming for high ferritin levels, had the best response with respect to hemoglobin levels. Nevertheless, as you can see, even oral iron treatment was successful. So if somebody doesn't like to have injection, particularly if patients are not on dialysis, they're on pre-dialysis, they have to come for injections or intravenous administration of iron to the hospital or to the praxis, they can go on oral iron if hemoglobin level is not too low and if response is appropriate. But two problems with oral iron: it is not very well tolerated, maximally 1 pill per day. 2 pills already cause diarrhea and other gastrointestinal problems. And secondly, the higher the inflammation, the lower is the resorption of oral iron. There is an association, and with very high inflammation, there is almost no oral iron absorption. So you have to switch to intravenous iron. What about the dialysis patients in intravenous iron? There we have a large study which actually changed the recommendations by KDIGO. This is the pivotal study, again performed by Ian McDougall and his colleagues from UK. It's a purely UK study, and they have administered high-dose intravenous iron in a proactive fashion, 400 milligram monthly, up to 700 micrograms per liter ferritin. Above that, I wouldn't go. I will explain why. Or they have acted in a reactive fashion when TSAT drops below 20, which indicates absolute iron deficiency. They have administered low-dose iron intravenously. The primary endpoint, because it was a large trial with 4,000 patients, was hard endpoints like myocardial infarction, stroke, hospitalization for heart failure, death, and so on. And this is the result. Here is the iron dose, significantly higher with the proactive administration. And what was really surprisingly for us, because it was long told that iron might be also adverse effect to spear infection and so on and so on. No, there was even a better performance of those patients having higher dose proactive administration of iron. And importantly, there was no significant signal for adverse events with respect to infections. This was published later on. So there was no more infections in patients having higher dose iron administration. So this could be the approach in hemodialysis patients to improve anemia. However, be cautious. I told you not above 600 to 700 ferritin, because what then happens, we know very well with transfusions, you get hemochromatosis. This is a nice picture of MR liver, a scan. You see here iron, how it is deposited in the liver if you exaggerate and administer too much iron. So you have to be careful not to overshoot with respect to ferritin. What about the next step? The next step was a major breakthrough in treatment of anemia related to CKD, the introduction to ESAs, a biotechnological achievement, because these are one of the first biologically produced drugs. And this is a very highly cited paper by Professor Eschbach from United States. And what you can see here started the ESA treatment in United States. There was a dramatic drop in transfusions no need of transfusions. And this is very important because there was always a discussion, either not a yes or no because of adverse effects. There is no question of giving ESAs or not, or to treat patients with anemia, because it is calculated if we would have to supply those patients with blood, this would use up to 20 to 25% currently of the blood resources in the Western world. So you cannot go back to transfusions. We have to use these drugs. But there is a word of caution. And this came from many large studies, two of them important choir, and particularly the TREAT study, the largest one with more than 4,000 participants in patients non-dialysis. The GFR was roughly about 35 milliliters per minute, and there was mortality and all other hard endpoints assessed. There was actually no difference between the hemoglobin level achieved of 13 and 9. But there were some problems like stroke, thromboembolic events, and even there was supposed to be more malignancy. The later on was not confirmed. There is no fear of malignancy in these patients, but I have to say stroke is an issue, and there is another issue, thromboembolic events, thrombosis or fistulas. So that now the start of ESA treatment is usually in very carefully, and the starting hemoglobin level, as you can see, always is around 10. So when hemoglobin falls below 10, then this is the latest point when anemia treatment should start, particularly in dialysis patients when hemoglobin level falls below 9. So 10 is the trigger point for starting ESAs after you have already administered iron and replenished iron stores. However, and now it comes to the however point, have a closer look at the trial, at the TREAT trial with Aranesp, with darbepoetin. And actually, the trial was a randomized prospective trial where darbepoetin was tested against a rescue therapy. It was a rescue therapy with placebo. And this is the achieved hemoglobin levels in the darbepoetin arm, and this is the achieved hemoglobin level in the placebo arm. And we are almost never looking at this, but it is important because this was the difference, and the difference was not 4 grams per deciliter hemoglobin. It was only, as you can see, from 11 to 12.5, so 1.5. Actually, according to the study protocol, the difference should be here because it was a rescue treatment, and these patients here should have been at a hemoglobin level of roughly between 9 and 10. So what we actually have with the TREAT trial is not a comparison of low versus high hemoglobin, it's a comparison of, let us say, higher and even higher hemoglobin level. And it is a perfect proof that iron administration works because the high hemoglobin level in this arm was achieved with significantly more iron administration. Therefore, the KDIGO guidelines and also the ERBP, so the European Best Practice Guidelines, say individualization of treatment is reasonable in patients who can have a higher hemoglobin concentrations, and you must not wait to start the treatment when hemoglobin level falls below 10. Or practically, if you have a young patient who, for example, lost his kidneys by accident with a hemoglobin before 15, there is no reason to have that this patient has a hemoglobin level of 15 even after that, if he feels good and there are no problems with cardiovascular events and so on and so on. What about the target level? And this comes from these studies, and as you can see, the target level is set as the trigger point is 13, never goes below 13 to prevent thromboembolic events. And it's not MACE in cardiovascular events, clearly it is thromboembolic event. And so the target for the hemoglobin would be somewhere between 11 and 12. But I can assure you it's almost impossible mathematically to have such a narrow target. You always a little bit overshoot, or it's below the target. And then we come to a very important point with respect to ESA management. This is the ESA hyporesponsiveness, or in other words, the resistance to the treatment with ESA. We have two kinds. Initial resistance, where there is no increase in hemoglobin levels from baseline with the initiation of ESAs, or the later ESA hyporesponsiveness, when you have to steadily increase ESA doses to maintain hemoglobin concentration. This is better depicted on the next slide here, published by Salomon in the New England Journal. The left-hand side, you see the early phase. So this is done, or these are data from the TREAT study. Therefore, here, darbepoetin was the treatment compared to placebo or rescue therapy. And as you can see, what means treatment resistance to ESA? That means that you have high doses of darbepoetin to achieve quite low hemoglobin levels, and those patients responsive need only low doses to achieve target levels. And in the later phase, you have to increase further and further the dose of the ESA to maintain hemoglobin levels. So this is the unresponsiveness to ESA. And there may be many, many reasons for that. And there is also a check what to do with such patients. It's a kind of standard operation procedure, what to do with patients that are resistant to ESA. When we talk about ESA resistance, for example, if you have a short-acting erythropoietin alpha or epoetin beta, and you have a weekly dose of more than 20,000 units. Above such doses, we clearly say there is a treatment resistance when you need such doses to stabilize hemoglobin levels. And one important contributor to this hyperresponsiveness is serum CRP, is an indicator of inflammation. And now we will switch very shortly back to the causes why inflammation takes part in our patients. And for decades, we didn't really know. And we have made own research, and this is published, you see here recently in Circulation. This is our research center established together with Aachen, where we are exploring the causes for high cardiovascular deaths in our patients. And this is an overview about lipoproteins. Why I'm talking now about lipoproteins. As you know, lipoproteins are important cardiovascular risk factors. But what we a bit neglect is that in renal patients, the big problem is not so LDL, because it decreases this progressive kidney disease. Also, it's a contributor to cardiovascular disease. HDL also decreases, but there is a tremendous decrease you see here in very low density lipoprotein levels, which is actually triglycerides. And if you look at your lab values of your patients, you will always see that triglycerides are increased when kidney disease progresses. And the main part of triglycerides is ApoC3. It's a molecule, it's a key, or the nucleus of triglycerides, and it's a transport protein where all these other lipoproteins are stick to. And we have shown and published recently, you see here in Nature Immunology, a paper on ApoC3 and triglycerides in CKD patients. And as you can see, compared to healthy patients, it's highly increased. And in parallel, there is increase of interleukin beta. Interleukin beta is the major contributor or the major effector molecule of inflammation. Almost all pathways of inflammation have interleukin beta as the effector molecule. And to make it very short, because this was a complicated preclinical study, what we have explored and what we have found, that this molecule, which is significantly increased in triglycerides in our patients, activates the so-called inflammasome, which is a defense mechanism against bacteria, virus, and so on, but it activates this through an alternative way and causes inflammation. So to say the story short, patients with chronic kidney disease have high levels of lipoproteins, and these high levels directly trigger the inflammasome and causes inflammation. And it's even worse because we have so-called post-translational modifications of these molecules in our patients. You know, probably oxidation of LDL, but there is also carbamylation, there is altered proteome, and so on. The most known altered or post-translation modified molecule is hemoglobin 1,8C, which is used for monitoring of diabetes. That's a post-translational modified molecule. But also lipoproteins are modified in our patients to a large extent. And we have very recently published in JASN this paper showing that ApoC3 is heavily modified. As you can see, this additional spike is guanidylation of ApoC3. And this ApoC3 is even more toxic and produces even more inflammation in our patients than the native molecule. And this is shown in our large cohort from our hospital, where we could see and show that the higher this post-translational modification, the higher is the inflammation, the more is the end-stage kidney disease and cardiovascular outcome compromised in our patients. So, summarizing, there are many modifications, not only of lipoproteins, also of albumin is modified. All these proteins are modified in our patients, and all these proteins can cause some kind of inflammations. And this leads to this heavily inflammation. And coming back now to the pathophysiology of anemia related to CKD, we have a very important molecule, a key player that is responsible for the endogenous availability of iron in the body. That is hepcidin. Hepcidin regulates actually the dietary iron reabsorption. And hepcidin is a molecule which has a direct receptor for interleukin-1 beta. That means the higher the inflammation, the higher the hepcidin level, the lower is the iron availability in our patients. So inflammation triggers directly hepcidin increase by the effector molecule interleukin-1 beta. This triggers reduced iron resorption and reduced iron availability in our patients. And now we come in my last talk to the HIF Prolyl-Hydroxylase inhibitors and how we could overcome this problem of reduced iron availability in our patients with this class. What are HIF-PH inhibitors? I'm quite sure that you all have heard a lot about that, and even the Nobel Prize, was given for the characterization of HIF, the so-called hypoxia inducible factor. It's a factor in almost all cells that have a nucleus in our body that senses oxygen levels. But most importantly, HIF is in the kidney where hypoxia is sensed and where it elicits a response by producing erythropoietin or inducing transcription of erythropoietin and formation of red blood cells. How does it work? At normal oxygen levels, and this is the critical step, oxygen binds to HIF Prolyl-Hydroxylase. That's an enzyme and then degrades, binds to HIF subunit alpha and destroys it. And therefore, HIF is not going into the nucleus, no transcription takes place. However, when we have low oxygen levels, then the receptors for oxygen or the oxygen sensing in this enzyme is reduced, the binding of oxygen, and therefore, as you can see, the enzyme is not activated, and this allows HIF to survive the degradation, to go into nucleus, and to perform the gene transcription of erythropoietin and other genes. And just as an example, that you see that HIF is not only in the kidney fibroblast. This is a nice study from Germany, and they have visualized HIF-1 alpha subunit, as you can see in the blood smear. These are erythrocytes. They do not have a nucleus, so there is no HIF in those cells because they cannot produce and express it. But this is a leukocyte, and they have done the following experiment. They have taken normal healthy individuals in Munich, you see here, and then they have gone to Little Matterhorn, which is roughly 3,500 meters higher, and induced hypoxia in these individuals. And as you can see here, normoxia, the above slides, and hypoxia. And this green light is HIF in this leukocyte. So we have HIF everywhere, and we know that HIF can also induce erythropoiesis in anephric patients. Even in patients without any kidney, this is done by induction of EPO transcription in the liver. And how now this new class of drugs acts? The PHD2 inhibitors, or the Prolyl-Hydroxylase inhibitors, HIF Prolyl-Hydroxylase inhibitors, are actually small molecules. They bind to this enzyme, blocks the binding site, so no oxygen comes there. It mimics hypoxia, and therefore transcription of erythropoietin takes place. And we have now at least 5 of these new representatives. As you may know, in Japan and China, many of them are already allowed for treatment of CKD-related anemia. In Japan, they have already 5 substances, and I will focus a little bit on roxadustat because of this action on hepcidin. Because these substances have in common that they improve erythropoiesis not only by EPO production, but we know that they also induce the transcription of EPO receptors. They induce also the improvement of iron resorption, and they can reduce hepcidin. And this was particularly shown for roxadustat, and I will show you some studies. I will not go into details that all these studies increase hemoglobin levels. You already know that this was published. This is not really new data, but as you can see in the very early studies with roxadustat, there was a clear-cut dose response reduce of hepcidin levels. And there are 2 newer studies from China, one in non-dialysis patients here, and one in dialysis patients. And what was important in these studies, they specifically looked at inflamed patients, those with a CRP below 4.9 milligram per liter and above. And what they have seen is that with HIF Prolyl-Hydroxylase treatment with roxadustat, there is a significant reduction of hepcidin compared to placebo, and the availability and the usage of iron was significantly improved. And this was confirmed also in hemodialysis patients who were even more inflamed. As you can see here, 305 patients. And importantly, the comparator here was not placebo, but EPO alpha. And with the ESA, there was no change in hepcidin, but with the HIF Prolyl-Hydroxylase inhibitor, there was a significant reduction of hepcidin again. And now we come to the end of my presentation. And as you can see, this was finally a better response in hemoglobin level because, and this is a complicated slide, you see here on the left-hand side in blue, the response to roxadustat. And it doesn't matter if the patient is inflamed or not inflamed. With the treatment, the dose decreased despite, as you can see here, despite stable hemoglobin levels. This was not the case with epoetin alpha, where you had higher doses with those inflamed but lower hemoglobin levels, a classical sign of partial ESA unresponsiveness or resistance. So that I hope that in the next update of the KDIGO guidelines, of the anemia guidelines, but this will certainly not be this year, probably next or even 24, there will already be included this new class of anemia drugs, the Prolyl-Hydroxylase inhibitors, and of course a chapter about hyperresponsiveness and how to manage this hyperresponsiveness in our patients with this new class of patients. So I'm at the end of my talk, and these are the two main important take-home messages. Anemia in our patients is a serious condition associated with increased morbidity, mortality, and particular reduced quality of life. And if Prolyl-Hydroxylase inhibitors are a new treatment option that could particularly be helpful in inflamed, ESA-resistant patients because of their mode of action. Thank you very much for your attention, and I'm happy to take your questions. Well, and that's my hometown, Heidelberg.
Thank you very much, Prof, for your review. It's really refreshing. And let me check for the questions from the people. Okay. There is actually two questions coming. They are asking about the relationship between the high liver enzymes and anemia.
Excuse me, about
high liver enzymes and anemia, the relation of high liver enzymes to anemia.
To be very honest, I'm not really aware of the relation between, a direct relation between liver and anemia, because the EPO production in the liver is usually suppressed when the kidneys are performing well. So liver EPO production is very important during embryogenesis. It is half of the EPO production, but when we are born, the liver EPO production is completely suppressed almost. It's not more than 5% of the EPO production, and the kidney takes it over everything. However, there might be an indirect relationship, as I pointed out. It might be that this universal inflammation, or the conditions causing this universal inflammation, are causing anemia and a liver damage parallel. But as far as I know, there is no direct association.
Okay. There is other questions. What is the next step for patients who received AZA and hemoglobin level has increased? Should we introduce iron supplements?
Well, that's, I have to admit, the wrong way. As I pointed out, according to the KDIGO guidelines, iron is the first preferred treatment for our patients, be it orally or intravenously. So first, and that's the problem we have, because I have to say, I see it also in Germany in the praxis, the physicians do not look at the iron stores. First, you have to see in your CKD patients, be it non-dialysis or non-dialysis, are the iron store replenished. If they are not replenished, if TZAT is low, you have to replenish iron store, orally or intravenously. The second step done is ESA, the introduction of ESA. If you go the other way and you already have ESA, then of course, if ESA will use up all the iron stores, you will come at a point where you have to give iron, otherwise the ESA will not work anymore.
Sure. Question, can iron with B12 will help to overcome anemic conditions instead of alone?
But B12 is only indicated in the quite very rare cases where there is a deficiency of vitamin B. You see it very nicely because this anemia is not like a renal anemia. It's not a normochromic normocytic. It is probably macrocytic anemia where B12 deficiency is in the place. So then it could be a good option, but this is quite rare conditions. Usually, I have to say, in malnourished patients, sometimes in patients prone to alcoholic intake, they have problems with vitamin B12 resorption. Or patients who had a gastrectomy or intestinal operation, they also have a problem. Then it could be, then you have to give B12 to improve anemia.
Great. There is also one question which is same as my questions. What about patients in dialysis with hemoglobin high spontaneously without ESA and iron deficiency? Should we replace iron deficiency?
That's a very interesting, very important, and very tricky question. We have patients, particularly polycystic kidney disease patients, who do have normal hemoglobin levels, even when they are on dialysis. However, there is a difference. There is anemia related to CKD, which is multifactorial, as you have seen, related to iron deficiency, inflammation, ApoC3 deficiency. But on the other hand, patients can also have pure iron deficiency. And there are many studies also by nephrologists showing that, for example, iron is a very important molecule for the performance of muscle enzymes. And patients are fatigued. They feel fatigue if they are iron depleted. Yes. And you will see if somebody is severely iron depleted and have normal hemoglobin levels and you administer iron, he will feel or she will feel better because muscles will work better and also other organs. So if there is an absolute iron deficiency despite normal hemoglobin levels, that means a TSAT below 20, I would replenish it.
Okay, we have here two questions regarding the HIF. Is HIF-R effective in case of EPO resistance cases, whatever the cause of resistance?
Well, they are. We have this discussion recently, and so far there are very, very few non-responders to HIF Prolyl-Hydroxylase inhibitors in all the studies. No matter if it's Roxa, Dapra, Vadadustat, it doesn't matter. In all these studies, we have very low non-responders. And personally, I believe these are patients who have a problem with their bone marrow. We have many patients receiving immunosuppression therapy, for example, for their glomerulonephritis and so on. They receive bone marrow depressive drugs. And of course, if the bone marrow does not respond, it will not respond not to exogenous and not to endogenous erythropoietin. And it can happen that then we also have non-responsiveness to HIF. But these are, again, very rare conditions.
Yeah. And the next question is also regarding the HIF. After how long we should monitor response of anemia?
It's the same as with ESAs. The same as with ESAs. It is quite, when you look at the studies, and I have shown you just one study, but I could show you every study, be it with Roxadustat, Vadadustat, Daprastat, the response with the doses chosen is almost the same when you take an ESA in an appropriate dose or an HIF Prolyl inhibitor in an appropriate dose. Even there was a slight overshoot in the HIF studies with HIF Prolyl-Hydroxylase inhibitors. So I say it is maybe the same as with ESAs. Start low and go slow and monitor hemoglobin, not to overshoot.
Yeah. One last question is about HIF also, the mode of administrations. He's asking about, can be administered IV in the future?
Just oral. Well, I didn't mention, but this is possibly a huge advantage. You just have to give it oral. Roxadustat is the exception because it's taken 3 times a week. which can also be an advantage in dialysis patients. They take it on a dialysis stay. The other HIF Prolyl-Hydroxylase inhibitors have to be taken daily as a pill, one pill.
Yeah, and there is also questions about, is it safe to use HIF with malignancy?
Good question, a very good question. So far, we have large studies with all these substances, and there is so far no safety signal, no safety signal. However, most of those studies were rather short, 1 year, which is not very long for large studies. And despite having several thousand patients treated now with Dapra, Roxa, and Vadadustat, we can say at least currently there is no safety signal with respect to malignancy. But of course, none of these studies were done specifically in patients with malignancy. So we have no data specifically as we have with ESAs, where we have data specifically in patients with ESAs. And just one word of caution, those studies with ESAs have shown that the problem with patients that have malignancies is not the progression of malignancies, it's thromboembolic complications. Most of the complications in these patients were thromboembolic events. So I would be also careful with HIF Prolyl-Hydroxylase inhibitors, because we know from the studies that they have the same level, have the same level of thromboembolic complications as ESAs.
Okay, I think we still have time for one last questions, because keep asking the same questions for me. It's what is the best way to administer Aranesp before termination of dialysis or give subcutaneous after dialysis, from your experience?
Well, usually we do not administer it intravenously. We administer it subcutaneously. And
Yeah.
but if we use darbepoetin, we go on a 2-weekly schedule, not a weekly, a 2-weekly schedule, subcutaneously. That is our schedule, but of course you can do it also weekly.
Yes. Okay, I think we covered most of the questions today. And okay, so we are on the time actually, and by this we would like to thank Professor Danilo for this really fantastic review of the anemia, and thank you very much for all the attendance this evening. And I would like to say special thanks also for the Saudi Society of Nephrology and Transplantation to offer this great webinar. Thank you very much.
Thank you very much. It was a great pleasure.
Thank you.
Greetings to Saudi Arabia.
Thank you very much. See you. Thank you very much. Thank you.
Bye.